is that the device is compressing the pulmonary veins. Still year 2000s, we still have the same problems. So he understood that replacing the heart was still not good enough. And he focused in this institution onto the left ventricular assist devices, which his term, he used the ventricular pumps. And when the pump is, this is the Liotta and DeBakey pump, which has been prepared for one side, and this is the first clinical LVAD, successful LVAD implantation in the world in this institution. I think we should take a lot of ownership on this, and I realized that not many people knows about it. I didn't know about it much. That when I was preparing through the years with Dr. Fraser and stuff, I learned, but this is something really big and important. So this one was a 37 years old lady. It came from Mexico with a aortic regurgitation and mitral stenosis. And he planned this, which is also a great thing about the LVADs. LVADs cannot be placed without implant and as a bailout. It should be, there shouldn't be any emergency unless it's you. Now we have good technology, but I'm thinking all the time, we used to go to OR with the CPR and chest compression, and then, you know, Dr. Fraser used to put these pumps, and then everywhere is blood bed, and then even anesthesiologist making a joke, should I give the blood to the patient or throw it on the floor? So it was not the surgeon's fault. It was not it was the bad, I mean, the patients were already dead, and then when they are dead, they don't coagulate, they don't, acidosis, all those bad factors make them bleed. And so this one was a planned, and they know that it would, you know, after not be able to come the cardiopulmonary bypass, he had a plan to put this pump between the pulmonary veins and giving it in the axillary artery. This is also amazing thought that I just, after the recovery, not when we're removing the pump, not creating too much trauma to the patient. And she survived additional 10 days on this pump, and there was 2 attempts, but it was unsuccessful. They kept going to support, and finally they separated the patient from the pump, and then patient lived another 9 years in Mexico City as a hairdresser, and unfortunately died from traffic accident, not even cardiac death. And since then, there has been a lot of similar idea, a lot of pumps during the 70s, 80s, which is one of them is a well-known Thoratec paracorporeal pump, and then the switch to XVE, and which is a implantable, durable pump. And with this pump, we finally in 2001, we sealed the showing left ventricular assist devices improves survival, saves lives. This one was a big cornerstone for the LVAD devices, Rematch trial. And there was a statistically significant reduction on the death when you compare with the medical treatment. And 1 year of survival was 52. But this one was a big pump, and the problem was also the durability. And so it was usually around 36 months, the pump was wearing off, and patient coming to the ER with the hand pump, trying to keep them alive and rushing into the operating room to change the to the pump with the replacing with the new one. And then the Renaissance came, and this is little sophisticated wording for me, so I'm going to read it. That this is Botticelli. That's the most famous Renaissance artist, and the Rebirth of the Venus is the most famous painting. And from ancient times, the pulse has been recognized as the most fundamental sign of life. It is all those physical examination techniques that doctors have to diagnose. And the Renaissance is that the revival of ancient classical ideas. So we had to change something because the pulsatility was taking a lot of space. And so that change caused that life is possible without pulse, which we always, through the 6,000 years of history, the pulse was the sign of the being alive, and anything that when you want to check somebody is alive, you go and check the pulse. So it was the idea totally changed, and Dr. DeBakey played a major role on this again, and with this his vision, because he knew that there should be a smaller pumps. So they talked with the NASA scientists, and incredible work done at that time, and they came up with this small pump. And DeBakey and Noon pump, which is also a big revolution that we need to have an awareness of this historical moment. And Dr. Noon is a major surgeon. I had a privilege to work with him too. He's our Captain Midnight. I personally seen him putting the catheters in the middle of the night, that where the intern is supposed to do it. And he used to, in the MICU, putting a catheter to the patient. And so this pump was a very important rotary pump. It's a different as the start of the Renaissance. Never got FDA approved in the United States, but the 44 patients is been implanted in Europe, and this is the first pump that demonstrating that compatibility of the continuous blood flow with the adequate tissue perfusion, because people didn't bleed. I mean, there are still some people doesn't believe in continuous flow without pulsatility, that you're in the long term, you're damaging the organs. But this is the first clinical trial in Europe that's showing and proving that continuous flow provides the adequate tissue. Since then, a lot of devices came into the field, and Dr. Fraser used to say that still we are observing and recording, and that record is an Intermex. This is our data. Is showing that incredible advancement with the timeline and with the newer pumps. So here with the timeline during this recording, a lot of things changes. That we have. I think I need to go back. That I want to show. Yeah, here. So historical non-magnetic levitated. I just wanted to point out that's a HeartMate 2. And then non-magnetically levitated is a hardware, which is not, both devices not, we are not implanting them now. And magnetically levitated, which is the HeartMate 3, is the only device right now. So both devices, we made a lot of advancement in 36 months, 52% survival, to going up to almost 76% in 5 years, less than 50 years old people. So we had almost for young people, we had an incredible advancement survival of the 5 year is almost close to the transplant outcomes. But despite all these the advancements, still we have problems in order to barriers to treating the less sick patients. A stroke is still a problem that Dr. DeBakey mentioned those in many years ago. RV failure, GI bleedings, infection, rehospitalization, and recently changing the reallocation system in 2018. So after 2018, in order to decrease the transplant waitlist mortality and transplant waitlist time, the organs donations start to give a priority to the sick people, and on reflection of that, the durable LVAD numbers are decreased incredibly. But what this allocation system it changed good things, but in the same time, we are transplanting the sicker people, and because of that, we have a little lower outcomes in the first year mortality. Well, that's the after 5 years now, again, waitlist time increasing because we are gaming the system. Everyone is getting a balloon pump in the ICU, and in order to get a transplant, and because of that also the wait list is getting bigger again. This year is 13% is bigger than last year. So we are going with a new answer to the old problems again. And so I don't think we should compete each technology and each modality. So there are patients that can benefit from either one. So especially the young patients who are non-ischemic, there is a chance to recover these people, and so maybe going for the LVAD is better for them, and versus transplant better for some other people. So combining this philosophy with what we have that's how we can lead the medicine. So need to assess the role of LVAD as a complementary therapy to heart transplantation to increase the total lifespan, using patients with marginal candidacy for heart transplant and patients who can have profile for recovery. So I think this is a concept that we need to bring it together instead of just doing one side and putting as a complementary. And it's a something that is opportunity for this Methodist hospital to lead the medicine. So this is one of the examples that I was involved with each surgery as a resident fellow and as a junior attending. It's a great story. This is a young lady and came with a non-ischemic cardiomyopathy, and we put a HeartMate 2 device, and she was in 1 year. And Dr. Frazier is the big proponent of the recovery. So we removed the device after 1 year. And she lived 11 years without the device. And then she failed while she was in the trip into the Colorado and came back. And we were in that time in Memorial Hermann. She came and we placed the hardware. And after that 2 years of hardware support, she got transplanted. And she had 14 years of without the transplant. And a young female in 14 years, I mean, if you look at the UNOS data, probably 75% she would be dead by now. But now she's starting something again, and then there's a retransplant. So it gives a pretty long lifespan. And I think this philosophy is very important and is not very much practiced in anywhere else, that we should take ownership and lead the medicine. So from here, I'm gonna take on the very important things that is ventricular recovery. And in 1950s, the Sam Levin and mentioned that that's how they used to treat the bed rest, that these people. And then he figured it out that if the legs are down, which is preload reduction, they get better. And he published this in early 70s. And you know, the same concept that when Dr. Fraser was putting these heart rate XVEs, and he observed that the patients in the chest X-ray, patients, the heart was getting smaller. And then when he started the wean, obviously, you know, they were doing fine. And then they published this great paper, which is one of the historical moment also for the LVAD history, that they do fine. And just almost like a transplant, if they are like a transplanted, the survival of that when the pump is removed is similar. So, but identifying these patients is the still we need to work on. There's a lot of work in that. Still we are observing and recording, and there are opportunities on that for the recovery. And again, it comes to the Dr. DeBakey's.
We would be able to support them for a period of time, days, a few weeks at the most, hoping that the heart would recover.
Again, his vision, it was correct. Now this is a time that he was talking and wrote about it, that after the ST elevated MI, acute myocardial infarction, and that time also for the transplant was a big problem. They needed to have a support for the heart. And for that, from that period, this is actually another revolution, that the HEMA pump, which is Richard Wampler went to Egypt as a mission, and got an idea about how the Bedouins are wheeling the water from the wheel with the historical Archimedes screws. And he created this pump, and this is the actually first successful history, not a clinical device or is a implantable device, but with a rotary pump in a clinical setting, they recovered this patient who was a heart transplant from Colorado and had a really bad rejection, and they put him on supported 46 hours, and during that time he was not making urine and everything was going downward, the liver enzymes were going up. They reversed all that physiology, and patients start to make urine and supported 46 hours, and during that time delivered the anti-rejection drugs and recovered the patient, and patient went home. And so this is the actually grandfather of the technology that we use today, which is called Impella 5.5 from Abiomed. And this is a great paper from Denny that looking at that I highlighted. We can 70% successfully wean these people, save these hearts in a cardiogenic shock, acute cardiogenic shock settings. So there is an opportunity here that we are practicing that in acute cardiogenic shock, that this patient came with a terrible end-stational disease, and in 60s, not a candidate for transplant or LVAD, and severe left main, and as well as right coronary artery. And if you look at the right heart caths, the wedge pressure is 28, PA pressures are increased, totally failing, cardiac index 1.9. This is a true, if he was suitable LVAD patient, but there is no other options. So here's the videos that critical stenosis in left main, and he is, and this is the ventricle. It's not moving at all. And then we put a Impella 5.5 on this patient, and then we supported him successfully. But the thing is that here, Impella 5.5 does not treat these patients. I mean, great work by Dr. Smalling, Richard Smalling, again, with using a hemo pump. He showed that in early 90s and published that these pumps reduces the area of the infarct, but it doesn't prevent the infarct. So still they are infarcting. So in a shock patient, these people still how we put these pumps, they need to be emergently revascularized, either surgery, which is not really where in these settings when they are really, really sick, or stent, PCIs. So this patient, after some time, got a PCI, and they're successfully revascularized fully. One thing is also important. We cannot just go to the culprit vessel. It needs to be full revascularization, so we can, because there is already EF is less than 15%. And here, the ventricle is still, now it's time to support this little bit again, and after serial right heart cath medication, we took this pump out, and I think he's about to go home. So this is a great opportunity for this institution using these pumps to lead in this sense of the shock patients as well. And so there are some data showing that how the successful the pump helped the physiology, cardiac output, and then the right heart caths, and I try to do that. And then the other one is also a patient, again, very sick, very, the LVEF is 20%, less than 20%, and goes and get a off-pump cabbage. And then 2 days later, before that, of course, it gets investigation. I know switch trial did not show any importance of the viable studies, but I think it's so important to have a viable myocardium on these people. So there was a viable myocardium, and Dr. Sweeney went and go ahead and did a off-pump cabbage, one vessel, and post-op day 2, if you guys look at he's getting in cardiogenic shock. In the second column right here, the lactate is increasing, LFTs are increasing. So we catch this moment, and then went on put a 5.5, and after that, he had a very severe right coronary artery stenosis too, and they are both revascularized. This is the Lima to LAD, and then here is the revascularized right coronary artery. And then this patient also about to be weaned off from this procedure using these pumps. And so another point is that after the surgery, when they are in postcardiotomy shock, it helps, and we can save lives. And the other part, that this hospital is a big organ transplant, and we start to use these devices in multiple organ transplantation. And then this is one of the first one with the liver cirrhosis, is heart function is about 30-35%. And what to do? Everyone is needs. We cannot do. Heart is not going to tolerate. We cannot do the liver transplant with that. So coming for a heart transplant, which where, heart is not that bad. Just in order to be able to do the liver transplant, we should do heart transplant as well. So we put the Impella 5.5 was placed, and patient got the transplant. And after the transplant, actually 5 days later, it's the Impella was removed, and about 6 months later, or a couple months later, recovered. I think the cirrhotic liver was creating some metabolic effect to reduce the left ventricular function. And now it's a recovered LV and didn't have a heart transplant, just auto transplant sort of. And another opportunity, we are amazing. We have an amazing department of and one of the prominent department for adult congenital heart disease, and I think this is another paper that I was participated with Dr. Fraser. This one was a mustard procedure, which is a atrial level switch procedure for the transposition of the great arteries. Dr. Cooley did many years ago, and switching the anatomic right ventricle, making working left ventricle. So these hearts, the anatomically right ventricle is not made it for a hard work, and they fail. And this patient that we placed the LVAD, and then after 8 years of support, he was transplanted. So I think there's a lot of work to do for lab and research on this subject, but it's an opportunity for these institutions to lead the medicine. I think we have already the Intermex data showing when you have a two ventricle using this pump, it works. But when you have a Fontan physiology, it's not that great outcomes. So maybe we need to go back to the total cardiac replacement therapies, total artificial heart for early stage with the devices on these people. So it's a very empty area that there is a lot of work can be done, and we can lead the medicine on that subject too. Another one is the EP, the VT ablations. We're using these temporary devices just to make it safe, and if the VT is broke, and because it affects the left ventricular ejection fraction, and so without putting them into the organ damage and the low cardiac output, we can support them and help those people as well with this device and collaboration with the VT cardiologist, EP cardiologist. So a lot of advancement is done with the technology. The pumps are getting smaller and more sophisticated. So we don't have these the complications. This is just because pump got smaller. It's a simple thing, but we don't have a pump pocket, so it eradicates this kind of horrible complications, which these people was surviving with they were coming to the clinic with the dressing changes and stuff. But through the year, for a lot of things, we still didn't make, there are some points that we couldn't make any advancements. I mean, for controller, that's the Baylor controller versus now the only device that total artificial heart controller. There's a lot of advancement, but then you look at this second picture where we putting it in, it's almost similar to like in 40, 50 years. There's not much difference in that part. So a lot of things when you compare with the computer technology, digital technology. This is in 60s where this work all started in 64. Now we have compact, small devices that even babies are just playing around. So that there is still a lot of work to be done, and this work can be done also, we can lead this through this institution. I think we should have invest on this, preclinical labs that we can bring any technology and in our hands try that technology on the animals and then translate it into the clinical space. I think this is the future, and that we should invest and lead the medicine through the name of the Houston Methodist Hospital. I need to put another device waiting upstairs in the transplant, so I'm going to cut. I don't know if the time, I don't want to take too much, but I think Dr. Duarte, what you said is like about 40 minutes. So, so we have some questions also.
Thank you very much, Dr. Akay. A nice overview. I love the historical perspective also. Notice also that with Dr. DeBakey's initial research was a collaboration between Baylor College of Medicine and Rice. And nowadays we have a very strong relationship between Rice and Houston Methodist, and I think it's amazing. Questions for Dr. Akay before he leaves and saves another person? Yes?
I don't know, am I supposed to use a microphone?
Yes, please. Microphone.
Thanks for the great talk. You've been at Texas Medical Center for some time. You've probably been in every institution except maybe HCA. I don't know, maybe you've been there too. I'm not sure. It's rather propitious timing of this talk because, as you know, probably this month the first artificial heart will be placed, the Bivacor across the street. And it'll probably be national, international news. I've seen the device implanted in the animals. I watched them post-operatively. They do very well. But now we get to the big step where they'll be put in humans. This is a total artificial heart. These patients will have one blood pressure. And I'd like to get your impression. What do you think is going to happen with this? It's going to be a big deal, I think.
It is going to be a big deal because if you look at whatever I try to mention too, that's the missing link still, is the replacement of the heart. And we have devices, but it's not satisfactory. That's why they are not picking up. I think the clinical use of the pumps or devices and the numbers reflects how much they get accepted. So the total artificial heart that we have right now is declining, and the entire nationwide and worldwide as well. So the reason is 1970s technology. I'm not saying it is bad thing. There's a time that we have to use that, but this is gonna be revolution again. This is gonna be Renaissance, because in total artificial heart sense, we still, like what we have XVE, we still have a large volume of blood is being pumped into I think that this pump that is coming up across the street is gonna be the renaissance of the total artificial heart. And I know Dr. Fraser always very enthusiastic, and he's a true believer things, but I know with the animal studies, the results are very good and everything is promising, and I'm hoping that it will be very successful because we need that pump.
Hi, Dr.
Thank you, Dr. Akay, for this great overview and great having you here working with us. That's been great. I just want to, especially for people who don't deal with this discussion every day, just want to get your philosophical, approach to this. As you said, we are getting so good with the LVADs. The outcomes is getting great. They just published their 5-year follow-up on the heart mate. 60% survival, like a 5 years. With
For young people, 76%.
76%, yes.
Less than 50.
We are so good with the transplant. Transplant survival has been great. This new pumps, the Impella 5.5, now we can just leave them for a long time for either recovery or bridge to transplant. So, our team, we had the discussion on a daily basis. I know there are some of the patients, they're not candidate for one versus the other, but there's a good number of the patient that you can go either way with the VAD versus the transplant. Just want to kind of your thought process, how you approach that for maybe decide about this patient.
Well, I mean, again, I think it should be complementary to each other to expand the lifespan of the patients. So there are exactly ones that is good patients good for the transplants. There are they are young patient, and we have that data now, and if they are young, if they are non-ischemic, I think we should go for the LVAD. Because one thing also, Dr. Bimaraj is also working and starting is recovery. I mean, the recovery is important. Because of this new allocation system, we are rushing people to the transplant, and we are losing 13% of people who could recover with the LVAD support. So 13%. I mean, this 13% is not small, because the glass is empty, and 13% is a lot of patients. What we do, because we are doing a lot of things to save one patient, right? So that is important to catch that group too. And my philosophy, which is directly related to Dr. Fraser's philosophy, he is the philosopher, I'm not. So it's for young people, for recoverable people, put an LVAD, and then just support them. And if they don't get any the complication of the LVAD, you can go as much as possible, and then give, like this lady, 14 years. That's a huge thing, because in 14 years, a young lady, most of them would be dying, according to the UNOS. So this philosophy is really important, and actually is not really applied very vigorously between the centers. And I think we should focus on that, with looking at if they are young, if their PA pressure is low, I mean the non-ischemic for LVAD, and try to recover them even, and closely follow up. And whenever they need, we can transplant them or put the device back in again.
Dr. Guha.
Fantastic overview, Dr. Khan. So, in the first 20 or 40 years of LVAD development, there's been a lot of improvements in pump design, and we've seen, it's almost as if we've reached a plateau in terms of the improvement in pump design, but still you have the same complications, albeit at a much lower rate. You think for us to achieve, near perfection, where all the complication rates even fall even further, where do you see that we can make move the needle? Is it more in better medical management of these patients, or is it continued improvement in pump design?
Well, I mean, I think it's the both, and we know that from the roadmap trial, I mean, the medical management changed a lot of outcomes. So that's important, like it's been shown, and also design as well. I mean, the pumps are, it's still all technology, and unfortunately, because of this reallocation 2018, the number is going, and this is all about money. Like federal government doesn't have whatever they gave, like in 1964, $230 million. That's huge money. I mean, nowadays it should be billions and billions of dollars. I don't think federal government giving any research money that much. So it is depend on the industry, and it's like a product. And when we have limiting the product, and now it's one company, and so it's so hard, and developing these things is so difficult too. because you have a FDA benchmark. I mean, Dr. DeBakey's pump never got a FDA approval because never got funded to get that in the US. And so expensive technology, expensive approval, FDA makes things so difficult, and it's hard to reach that point, I guess.
Dr. Bemraj.
Okay, thank you very much for a great talk, and I want to second Ryan's statement that you've been an amazing addition to our team, and we thank you for all your work and innovation that you do. And I agree with your comment on the recovery. I think the field of VAD recovery has been underappreciated and pushed. There's almost 500 explants from across the world that the VAD vein recovery they're getting ready to publish. So it's a fascinating world to kind of prioritize that. My question to you is specific to MCS, durable MCS for ACHD patients, and it's a very complicated surgical investment is what I perceive, not being a surgeon. And when you have these complex anatomies, I almost feel that every patient will need a different strategy
Correct.
of mechanical support systems. How do you factor that into a trial and approval? Because it's almost like you're tailoring a pump, some kind of a circuit. And I've seen some of these typically, actually, I feel like some of these pumps that in the old school that you put in, some of the ones that you do, you're modifying the circuits to adapt to the patient. Are people working on this paradigm where you can actually get the basic infrastructure of the pump approved, but you have the ability to tailor the circuits in such a way that you can adapt to the complex circulation?
Well, I mean, I have really limited experience with, but I know one thing. When you have two ventricle with the congenital diseases, I mean, it works the similar way to the other non-ischemic or ischemic cardiomyopathy patients. The problem is the Fontan patients, and for that, I think is the cardiac replacement is the key. And when we have a device can show the durability and without affecting the end organs and adverse with the minimal adverse events, I think we need to go for not LVAD, cardiac replacement, and maybe nurse the patient, put the liver in a better position and the other organs, and maybe do a single ventricle, just the cardiac transplant. I think that having a good cardiac replacement therapy will improve those, address that problem in the adult congenital patients. Without that, because the solutions that you are proposing is temporary, and we don't have that time limit, because it can take a longer time to recover the liver or the GI system, because decompressing. I don't know even if they recover, but they will recover, I believe. I mean, young people, if you can just unload the right side in a proper way, you can avoid a lot of things, the liver transplant and the the enteropathy of the bowels.
Dr. Martin.
Maybe jump in a little bit. There's a lot of work in that field with the Action Network, which is the pediatric VAD network. It's the kind of grew from the Pumpkin trial, which was a pediatric pumps, which I always thought was a cute name. And they are looking at a lot of those things. I think, as Dr. Akay kind of pointed out, it is really the field divided into two areas, the double or dual ventricle patient and the single ventricle. And completely agree with Dr. Akay. The dual ventricle is very similar. Yes, there's some subtle differences, but for the most part, and honestly, for the most part, those patients are going away, because those patients were your old atrial switches, your mustard and your Sinnings, and that's not being done anymore. So you have the arterial switches. So the ones that you're looking at there that are the systemic right ventricles are just left over your L transposition, which is the most rare of the congenital, one of the most rare of the congenital abnormalities. And so you're not going to see as much of that, and I think it's really the single ventricle. There's some very interesting thoughts where they're doing, like a ventricular assist device on their ventricle, and then actually putting in micro pumps in the kind of pulmonary artery circulation to other stuff. There are a lot of interesting thoughts of where they're trying to go around and looking at that. But I think that data is really down the road, and I think the like I said, the action network and then some of the new focus on the adult congenital population is helping lead some of those things, which I think is going to be a great place. And I agree that excited to see where we can contribute to that field with the teamwork that we have now with both our surgical and medical team, and also honoring all the history and all the people who have laid the foundation for us to move that forward. Just a quick question, if, you know, as my kind of maybe catchphrase has been lately, in the land of rainbows and unicorns, what would you, if you were no limitations, is there something that you would, the next step for our mechanical support device that you would want to see move forward as far as either design or implementation or, you know, availability? Just, yeah, again, land of rainbows and unicorns.
So, you know, like, I like the rotary pumps, and they prove that we can save lives. But we know that we can save lives. But the durability is right now something that we are struggling, and extended durability especially. I'm not talking couple years or something. Maybe reversing the Renaissance and to the going back to with the sophisticated smaller devices to pulsatile physiology might give us a better long-term durability, because a lot of problems still we are stuck into the tissue perfusion. We are perfusing the tissues, but in the meantime, you know, like strokes are related with the aortic valve is not opening and closing, and all those things. So maybe is reverse. This is taught. I don't know. It's all hypothetical. I'm not saying I believe in non-pulsatility and all those pumps, but maybe it's worth to. That's why this place is important to try all those things.
Well, thank you very much, Dr.
Thank you.
Don't go anywhere yet. Just give me 3 minutes if you don't mind. Could I have Dr. Valeria Duarte come and join me right here? Well, as you know very well, Dr. Duarte, who is our champion of adult congenital heart disease and imaging, has been heading this grand rounds over the past 3 years plus. And we are indebted to her and Jennifer Collins. Unfortunately, Jennifer is under the weather today, to put together an amazing program over the years. We really have the best people sharing their information with us, be it cardiologist, cardiovascular surgeon, anesthesiologist. And Valeria, we cannot thank you enough for all the work that you've done. You know, this Grand Rounds, you may or may not know, is probably the most watched Grand Rounds in the world. You have about 300 live watch. By the end of the day is about 1,000. And it's watched throughout the world. And the only reason that people are interested in this Grand Rounds is the quality of what is taught, what is shared, and I think also the people that come and speak to us, be it local or be it national or international. So, Valeria, thank you very much for what you've done over the past 3 years. And this is in appreciation of your outstanding contribution to global cardiovascular education. Valeria Duarte.
Thank you so much.
Well, at the same time, we'll take a picture. At the same time, I would like to introduce our new director for Grand Rounds. Can you join us? Dr. Kershaw Patel. Dr. Patel is really one of the emerging leaders in preventive cardiology. His interest is cardiometabolics and prevention of heart failure. And I know he's going to take us to new heights. These are big shoes to fill, Valeria, but I know he has the capacity and the will. Can you say a few words, if you want?
Great. So for the future of cardiology grand rounds here in the center, we're really going to work on collaboration amongst ourselves as well as our cardiovascular surgery colleagues like we saw today, which was an excellent discussion, and hopefully start to build a little bit more community within before we begin grand rounds, as well as try to highlight lots of excellent speakers from the outside as well as internally. And we want to make sure we continue to build on the legacy that Dr. Duarte helped build from her predecessors as well. And we have a great forum and lots of exciting things lined up for the coming years.
Lovely. Thank you all for attending. Have a lovely day.